Hello, Dr. Mesfin. I'm ready when you are.
Yeah, I'm waiting for
He said start.
the word starts.
Start, he said
Is I?
start. Yes.
So, right, sorry for the delay. So, good morning again, good afternoon for those who are living in another place. Here is our presentation today is on pediatric clinical care of patients who have COVID-19. So, today's speaker is Dr. Elizabeth, and I will kindly ask Dr. Elizabeth to introduce herself in detail and to continue with the presentation. So, Doctor, the floor is yours now.
Thank you, Dr. Mesfin, and thanks for inviting me. I'm delighted to be able to speak with you today. As I spoke to my friend, Dr. Reddiot, I'm sorry it's not in person, but I'm thinking of you all. My name is Elizabeth Drum. I'm an anesthesiologist in Philadelphia. I work at the Children's Hospital of Philadelphia, where I hold a number of roles. I'm going to be talking today about COVID-19, and I'll talk a lot about pediatric anesthesia and non-operating room anesthesia. I'm going to see how I move my slides. Just give me 1 minute. Do you have to move the slides for me, or I can move them myself? Let's see.
I think the admin can help.
Let's see if I can figure out how to do that. I don't know if I can do it myself. I can find the remote. Okay. I have no disclosures. I am trained as a pediatric anesthesiologist, but I have cared for many adults in my career, although most of my talk is going to be focused on pediatrics. Most of my clinical time is spent in settings outside of the main operating room, although many of the things I say will apply to pediatric and adult care. And I'd just like to remind us that none of us, including myself, are an expert on COVID-19. We might think we are, we might act like we are, we might say that we are, but in reality, none of us are, because this is a brand new topic and a brand new virus, and we're still learning as we go along. I'd like to first start by saying thank you to my friend, Dr. Reddiot, for inviting me to speak today, and I would just like to send my greetings to her and her lovely family. Unfortunately, I haven't seen her since this picture was taken in December. I'd also like to say thank you to some of my other friends in Ethiopia, where I've had the privilege of being a visiting friend, speaker, and anesthesiologist many times over the last 10 years. My objectives today are discuss issues specific to anesthesia care of pediatric patients during the COVID-19 pandemic, to discuss issues specifically about care of patients outside of a traditional operating room setting, and also try to discuss the complexities of anesthesia care and highlight some of the differences between high-income countries and low and middle-income countries. So I'll start with this update from the World Health Organization from a few days ago about the number of cases of COVID-19 in all of Africa. And as you can see, this chart gives you the country, the total cases, and the total deaths. And it's a range in order of magnitude. So you can see, as of a few days ago, the location with the highest number of cases in the Africa region was South Africa. And you can see Ethiopia is sort of in the lower middle. Certainly places have fewer cases reported than Ethiopia, but there are some that have a lot more. And also you can see Egypt and Morocco as well have a lot of cases. Unfortunately, many of us expect this to increase over time, just like it is increasing even in my country still. And we have a lot to learn about care of these patients. Many of you may get this. I see this on Twitter. This is from a few days ago. I saw there was another one released today. And this is a notification from your own Minister of Health and officials talking about the number of patients. And as you can see, when you read this, most of them are not children, and most of them still have contact with other confirmed cases or travel from abroad. Although, as you can see on this alert, there is one person who has no contact with confirmed case or travel. So that means to me that COVID-19 is in your community and people are not necessarily aware of it. So as of the day that I posted this, there were more than 32,000 laboratory tests conducted and total confirmed cases of 210. I am not going to spend a lot of time talking about nuts and bolts of operating room management for COVID-19 patients. One of my colleagues and friends, Dr. Betty, gave a very nice presentation a week or so ago on this same program. And I urge you to look at her YouTube video if you're interested in understanding more about operating room management and anesthesia care. So a few days ago in the journal Pediatrics, an article was published in advance ahead of time online about infection and other clinical characteristics of COVID-19 in children. So this graph is taken from that article, and you can see they looked at approximately 75 children of various ages who were infected with the SARS-CoV-2 virus, which is the virus that causes the illness COVID-19. And you can see their breakdown of age ranges in here. The largest in this particular study was between ages 3 and 10. And then they detailed the symptoms at the onset of the illness. As you can see, about 1/3 had a cough, a little less than 1/3 had a fever, and then there were some other mild symptoms or mild and few numbers, things like diarrhea, headache. And then, as you can see on this graph, 37% of patients had one symptom and more than 20% had 2 or more symptoms. The other thing that is somewhat sobering to me, though, is to look at the clinical types of presentations. So almost 1/3 of these patients were asymptomatic. A little more than 1/3 had an upper respiratory tract infection and mild pneumonia. The point of this, I think, is that many children are asymptomatic, and those who are symptomatic, the vast majority of them will have what appears to be just mild respiratory symptoms. So with that in mind, I'm going to talk about pediatric anesthesia and care of pediatric patients during this COVID-19 pandemic. And if you have ever heard anyone speak about anesthesia in the past, these are the kind of things we talk about. Pre-op evaluation, what's our anesthesia plan, what do we prepare for in the operating room and afterwards. And I'm not going to go in a lot of detail about the average care of a patient for anesthesia, but try to highlight what might be the differences and especially things that you might need to pay attention to or think about in Ethiopia. In general, as we just discussed, pediatric patients have a lower incidence of COVID-19, and probably more importantly, many of them may be asymptomatic carriers of the virus. So it is certainly likely that these patients have a virus and you don't know it, or they have mild, what seems like upper respiratory tract infections. What we don't know, and it's not clear yet, is what happens to medically complex or fragile children who have the virus. For example, someone who has some coexisting cardiac or respiratory diseases and who then get infected with the SARS-CoV-2 virus. We've had a number of recent reports of patients in the United States with a Kawasaki-like picture. Primarily happens after the initial infection with the SARS-CoV-2 virus, and then they have a pretty significant and dramatic course with Kawasaki's like disease. We have a few in my institution as well. I have not taken care of them personally, but they're pretty sick. And it seems like the almost post-inflammatory response of the body to the virus in these children is worse than the virus itself. So it's important when seeing children who are going to have surgery or other type of evaluation, that we really understand their baseline medical history, specifically cardiac, respiratory, neurologic, because those have an impact on their ability to not only communicate with you, but also to tolerate or manifest complications of the SARS-CoV-2 virus. It's also important, and we'll get into a little detail later, about understanding family members and other contacts that they're around and whether or not they might be sick. So most high-income countries have greatly reduced elective or non-urgent surgical care. My institution as well cut way back on our planned surgical procedures, and I believe that that's true pretty much around the world. What's unclear to most of us is how is this going to impact our routine surgical care? We know that patients are still having medical issues, patients are still having surgical needs, but many of them are not necessarily seeking medical attention. And so many of us fear that by the time they do come to seek medical care, they will be in worse medical condition than they may have been initially. Patients are not seeking medical care because they can't get there, or because hospitals and other health centers aren't open, or they're not seeking medical care because they're concerned about being exposed to COVID-19. In addition, many hospitals and other health centers are not necessarily well equipped to evaluate patients. And I would imagine in your setting that most district hospitals and health centers are not necessarily prepared to care for patients with COVID-19. And so this will definitely lead to a straining of medical resources and care in Ethiopia, just as it is in other countries. And your health centers and hospitals may have to figure out plans for how you want to deal with the care of these patients. I think it's likely that patients with certain other comorbidities will have a worse time, and the care of them during the COVID-19 pandemic will be more complex. I don't think any of us really, specifically for children, have a good understanding of how things like chronic respiratory concerns or malnutrition or vomiting from typical diarrheal type illnesses will impact the course of someone with COVID-19. I think it's logical to believe that patients, especially children with those medical issues, will probably fare worse than otherwise healthy children. I think it's also probably true that in this current time, many people are not seeking routine pediatric medical care, which I understand is somewhat limited in most rural parts of Ethiopia. But importantly, I think patients will probably potentially stop seeking routine vaccinations and other care. I know that's certainly been the case in the United States. And I think that certainly puts pediatric patients at risk for other types of diseases like measles or other things that children routinely receive vaccinations for. So I think we all need to remember that children are still children, and there are still childhood illnesses which they are potentially going to be exposed to and may have. And so we need to keep that in mind when caring for them. And things that are important to anesthesia are still important. Things like NPO status, IV access, pre-op evaluation before we embark on an anesthetic for a child, rather urgently or when they're ill with COVID-19. I would just like to remind us that in the conduction of the anesthetic, we need to make an anesthesia plan in advance, and we should include all members of the anesthesia team, nursing and surgeons. This includes pediatrician, ward nurses, others who will be caring for the patient. More important than ever is the fact that we need to communicate about the care of these patients. And the time to begin this planning is before the anesthetic, before surgery starts. And this is really an opportunity to change processes and do things that are different. I am aware that in Ethiopia, sometimes it is difficult to plan in advance about the care of surgical patients, and adequately preparing equipment and supplies is difficult. But in these patients, this is even more critical than usual. So for the actual anesthetic itself, it will be important to plan exactly how we are going to conduct this. If we're planning a general anesthetic, how will you manage the airway? For most children, many times we do use an endotracheal tube for an anesthetic, although we certainly are adept at using laryngeal mask airways or even natural airway in which we administer sedation through an IV. But in this era of COVID-19, it's something we have to think about. There are risks both to the provider and potentially other people in an operating room setting by the use of airway devices, and we need to try to minimize risks to all involved. If the hospital or operating room or anesthesia department has an option for video laryngoscopy, the question is, should you use that? The reasons that people have advocated for the use of video laryngoscopy is for several reasons. Number one, to try to improve the visualization of the airway and make the first attempt the best and most successful attempt at intubation. And there are times where video laryngoscopy can really help in that. And the second reason is because use of a video laryngoscope means that the intubator is probably a little farther away from the patient's airway and therefore might be a little less at risk for being exposed to aerosolized particles. In addition, if you think that the patient might have a difficult airway, you should probably have a difficult airway plan. In cases where you would not necessarily normally use a muscle relaxant, you may want to consider using a muscle relaxant. You need to think about where you're going to place your dirty or used equipment because it's really not appropriate to put it on your regular workspace. And probably most importantly, you need to make a plan, an extubation plan, as well as an intubation plan, because the emergence and waking up from the anesthetic is as risky a part in terms of aerosolizing particles as the induction. I would say that in an anesthesia setting, you need to gather what you need, but not more than what you need. In US hospitals, we actually keep many supplies in our actual operating room, and we have stuff everywhere, and we have every size of everything that we might ever use. And in most cases, that serves us well because we don't have to leave the room to get what we need. And we also don't have to search for it. Unfortunately, during this COVID pandemic, we're trying not to keep everything in the room. My experience has been that most Ethiopian hospitals have trouble obtaining all the necessary supplies in the first place. And specifically things required for pediatric care is sometimes hard to find: the right size blood pressure cuff, pulse oximeter, medications, other supplies that are needed. But in this era, it's really important to get what you need and have it with you before you start. You also should plan and discuss about how you're going to keep emergency items available, but also clean, and so they aren't contaminated. Things that you might not normally use, you should get in advance. Things like muscle relaxant and reversal for muscle relaxant. You should really plan about how you're going to keep your emergency medicines available, but clean. Things like use in a plastic bag or some other covered area so that they're available, but not contaminated. And we should also plan and discuss not only our postoperative care in terms of location and what the patient will require, but also specifically about pain management. This is not the time to wonder how we're going to provide for pain management afterwards, especially in a situation where a patient is going to be in a ward with other patients, and we want to limit the exposure to all involved. Regional anesthesia may be an option, but only if you have the medications and supplies that you need in order to conduct it. But there is no evidence that there's any added risk or danger to providing regional anesthesia. So for some older children or teenagers, this is certainly an option. There's a few specific anesthesia related things that should be considered. And these are definitely difficult in some low resource settings, but I'd like to discuss them briefly so that you're aware of them. The first is the use of a high quality viral filter on an anesthesia machine. What this does is protect the anesthesia machine from being contaminated with COVID-19 virus. It also protects the environment so that as exhaled gas comes out of the patient, unless you have a scavenging system in place, it probably will limit
Sorry.
limit the exposure to the environment and those around it. Then you have to know where to place these filters, and I'll get in, show you a resource later. But typically, you want to have a filter at the patient end of your breathing circuit and one at the machine end to protect both parts of the exposure. There is a way to provide inline suctioning so that you don't have to disconnect your anesthesia circuit in order to suction. My expectation is that these are probably not readily available in Ethiopia, although it would certainly be worth seeing if any devices are available in some intensive care units. The point of these is so that you do not have to disconnect the anesthesia circuit or the ventilator circuit in order to suction an endotracheal tube. And if you do need to disconnect or suction, it is really best to carefully plan and time this, ideally so that the patient is not coughing, and also to ideally warn the other members of the surgical team so that they are not right in the area where exhaled gas or aerosolized particles might be. And if you have no way to provide filtration for your anesthesia machine, should you specify one particular machine or operating room or location where you will take care of COVID positive patients to try to limit exposure to any other patients or providers who would care for them. In addition, if you are lucky enough to have CO2 monitoring both in your operating room or anywhere else, it is also possible to examine the filtration capability of the CO2 device itself. And if not, you should be aware that potentially then the CO2 monitor device itself could become infected with the SARS-CoV-2 virus if it's not appropriately filtered. In many high-income countries, we have a lot of items that are individually packaged, cleaned, sterilized, have expiration dates, and most of us feel like this is a bit excessive, but there are actually times right now where keeping things individually packaged allow us to make sure that they are clean and not contaminated. You should probably be aware of whatever regulations your institution has, and there may be some Ethiopian governmental regulations about equipment, both how it's packaged and sterilized, that you should be aware of. But it's also time to ask your own experts. If you have experts of infectious diseases or microbiology or virology in your hospital or institution, you should find out what they are recommending. If there are standards for cleaning, both surfaces like operating rooms or supplies, or is there a way to keep things clean or decontaminate them afterwards? You should definitely find that out. And this applies not only for an operating room, but for a ward setting and clinics and any other places where you're going to see patients. And what of the equipment and supplies that you have can be re-sterilized to make sure that they're decontaminated. I'm going to specifically have a few words to say about the operating room environment itself. Most high-income countries have been advocating for the use of a negative pressure room for an operating room. And what this is really designed to do is to systematically clear all the viral particles and other airborne particles out of an operating room to limit the exposure to people in the room. Most high-income countries have documentation of the airflow within an operating room setting.
What is that? What are you going to say?
If you could mute your phone, that would be great. If there's any documentation of airflow in your operating room, then you can work with your facilities or hospital team to understand if there's any way that that can be altered. If not, then ideally you need at least an hour after any aerosol generation takes place in the operating room before you should clean it. Once the particles settle on surfaces like an anesthesia machine or other operating room surfaces, at that point, it is safe to clean them. But if you don't have a way for the particles to be cleared from the air, you really need to wait that hour. So at that point, then you can clean all the surfaces. Again, it's ideal to remove all the extraneous things in the clutter, to put them in containers, drawers, packages so that they have not been exposed. I'd also like to point out that it is important to think about the proper way to use a mask and glove and gowns and eye protection. I think it's particularly common in Ethiopia for people to wear their masks, but not to cover their nose, for people not to use eye protection, even if it's available. I notice in the United States, for non-medical people wearing masks, they do the same thing. Gloves, while maybe initially thought to protect you, the wearer, if you're not careful, can actually be a source of spreading contaminated viral particles and other things. So it's really important to use them correctly in a medical setting. I'm just going to show you a few pictures of my operating room and how we've chosen to restrict the flow and use our rooms. So we have a sign. This is the hallway outside of the ORs that we have chosen to make our COVID ORs. And usually if there's any patients in this area, there's somebody who's physically sitting here, standing here, limiting anyone's ability to go in there so that we limit the exposure. We have these rooms. This room is designed as our negative pressure room. It's labeled as such. You can only go in this way. You exit into the hallway of the previous picture. And there's usually someone at this entrance to try to limit the number of people that come in and out of the room and make sure that they're appropriately dressed. We have photos which show the use of an N95 mask. And you can see these people both have masks, they have eye protection, they have gown and gloves. So on the left, this is a non-sterile person. So this would be a nurse or an anesthesia person or someone who's not sterile for the surgical procedure, whereas on the right, they are using sterile glove and gowns. The same pictures are taken with what's called a PAPR, which is basically a purified air system. Can't really see too well, but on the left you can see there's a hose and an electric device that powers this. So it provides air and oxygen circulation for the person wearing it and also protects them. So in preparing for your operating room setting, you really need to think about where are extra people going to be located. So in the pictures I just showed you during the induction of the anesthesia, the only people are in the room that need to be there. So the surgical team is not in there. Most of the nursing staff is not in there, and they are outside preparing to come into the room. But you need to think about how many people do you need there when you have the patient go to sleep? If you have need for emergency supplies or medications, who's going to get them and where are they going to get them from if you don't have them in the room? And you want to make sure that your surgeons are immediately available, not somewhere else. And I think the other thing you need to think about is there any role for trainees in this setting? Many of our institutions in the US have determined that medical students and residents may or may not be appropriate to put in the immediate care of patients with COVID-19. We certainly have different regulations and rules regarding the amount of supervision for trainees, but there's also concern that although it may be somewhat of an educational experience for them, there's no point in putting trainees at risk. Obviously, for your own situations, you'll have to think about that. From recovery concerns, typically recovery takes place in United States hospitals in a organized recovery room setting. Phase 1 of recovery is defined from the completion of the procedure or the anesthetic through the time that the patient has regained consciousness and has a stable airway and vital signs. This part of the recovery period, usually from extubation until they're awake, is potentially one of the most dangerous times for other people in terms of exposure. It's not uncommon that patients need to be suctioned, that they cough, that they are certainly generating aerosols during this period. And so we, in most US hospitals, have made the change to take this part of the recovery and have it occur in the operating room. This is a big change for us. It's a big change in how we use our recovery rooms. It's a big change in the personnel, but we've decided that this is the safest thing for us and our patients. So it may be that in your setup, if you don't have a recovery area, you may still need to keep the patient in the operating room for a little longer period than you're used to. Or if you do have recovery room personnel, you may need to have them come and assist you so that the patient is through the most dangerous part of the anesthetic and the recovery in a contained space before transporting them to the ward. I want to spend a little time of talking about how to protect staff. And this is particularly for the operating room setting, but really could be anywhere in which you are managing pediatric patients, whether that be in the ward or an emergency department, especially in situations where patients can be generating aerosols, which are things like coughing, if they are having respiratory symptoms and need some type of respiratory support. Our definition of expanded PPE, which some people call full PPE, is really gown and gloves, eye protection, and some type of mask. Typically in the US, that would be an N95 mask or equivalent, or the PAPR, which is the air purified resuscitator that you saw. This is really considered sort of the gold standard of how you protect yourself. It's pretty clear that the SARS-CoV-2 virus is transmitted primarily between people and or contact with contaminated surfaces. And the way a person gets infected with the virus is by exposure to mucous membranes, primarily nose and mouth. So the most important thing is to protect your nose and your mouth and prevent any particles from getting in there. So covering them is the best way to prevent that. You can also really think carefully about the use of hats and shoe covers, and that's really to avoid contamination on the rest of yourself and your body, and that's really what the gowns are for as well. And that's really so that you would not be exposed to particles that then you might put in your face. You have to definitely have proper use of your face mask. As I mentioned earlier, that doesn't do any good if your nose is exposed, because that is an entry point for viral particles. Same with the use of gloves. Gloves might be perceived to protect you, but if it allows your hands to get contaminated and then your hands contaminate something else or your face, that is really not helping you. Soap and water is the best thing that you can use. It is, I understand, not always readily available in Ethiopia, but this is the time to advocate for this. Soap and water, if you wash your hands for at least 20 seconds with soap and water, you can get rid of the viral particles on your hands. If they're not on your hands and you have your mouth and your nose covered, it is unlikely that you yourself are going to be contaminated. Hand sanitizer is a good alternative. I recognize that it may not be as readily available in Ethiopia, but if it is, it's something that you can consider using or having in key locations to protect yourself. You really will need to discuss and think about how far apart to stay from one another. And I know that this is contrary to Ethiopian society and culture, but in order to protect yourselves, you will need to think about how you're going to appropriately stay distance, especially in a medical setting where you're not sure which patients are asymptomatic but still might be carriers. You'll need to discuss and manage your dirty stuff. And by that, I mean airway equipment in an operating room, but in a place like a clinic or an emergency department, anything that touches a patient that also touches someone else, a stethoscope, other equipment, monitoring abilities. You really need to think about how you're going to keep yourself protected and the staff protected, and also keep your equipment clean. Most operating rooms have showers. This would be a good time to really talk about and consider using the shower before you leave a contaminated space like an operating room and before you go out into the community and to your homes. The other thing, so this is a picture of me and one of my colleagues. Both of us are wearing N95 masks, and you see we have different types of eye protection. My colleague Heather has her goggles on. I have my glasses, and the goggles sometimes fit over them, but not as well. So this is a face shield, which is just made of plastic. You can see we both have our hair covered, which we need to do in the operating room, but we do at other places as well. Again, so that we don't inadvertently then touch our hair and then contaminate our faces. This is me in the more full PPE with the gown and the gloves and the shoe covers. And you can see my whole body is really pretty much covered. There may be a few areas of my neck and my face that are uncovered. So when I carefully take all this stuff off, I did wash my face and my neck. And then this was yesterday, actually, I took these pictures, and then I took a shower before I left work. And this was for the care of a COVID positive child. So the other thing you need to do is protect the patient. And this, again, will be difficult in your setting, but it's something you really need to think about and you should talk about in all of your settings that you take care of patients. First of all, try to limit the number of family members with a patient. I know that, again, is particularly difficult in the Ethiopian society and culture, but it is one of the best ways to try to limit the exposure and then the spread of the virus. Obviously, pediatric patients have special needs for things like their routine care, bathing, dressing, eating, but ideally limit the number of people who have to be there to provide that care. You'll have to remind yourselves, but also your patients, that eating represents a time where people are definitely exposed to others. So not only a shared meal, which again, I understand is a difficult conversation to have in Ethiopia, but also the fact that even if you are wearing a mask, when you're eating, can't be wearing a mask. And so that is a vulnerable time. So you really should think about how to space people out and how to limit the amount of interaction that you have with others. There are other things that we do in groups, though, that expose us. We cough, we sneeze, we sing, we shout. We have groups of people interacting, and those represent times where viral particles can easily come out of my mouth and get into your face. And so you really need to find ways to cover your face, remind your patients to do this, encourage people not to touch their face, which is hard to do, and really stress and encourage hand washing. In all of our cases, I think it's really important to really have serious discussions about emergencies. We should really try to avoid the delays that then lead to emergency situations. And in the rare cases where we feel like there's emergency things that have to proceed, it would be ideal to discuss these in advance, use simulation, practice scenarios to try to understand the workflow, which personnel you need, what equipment and supplies you need, and identify that in advance so that you can prepare for that. And only you can know what are the most common pediatric emergencies in your setting, whether it be the operating room or the ward or a clinic or an emergency department, so that you can prepare and have a plan. It's also, I think, important for you to understand what the prevalence of COVID-19 in your area is. The report that I showed you earlier is an overall summary, but I'm sure you may have access to other more regional reports to really help you understand how likely it is that the virus is circulating in your community. And again, remember that children might have no symptoms, or they may have what you consider mild respiratory symptoms. And finally, from an anesthetic and surgical point of view, there are definitely some ethical things that you should think about. How do you decide what is a necessary treatment? It is a difficult thing to say to a patient or a family member that you can't provide treatment. It certainly goes against everything in our US healthcare system that we have striven for decades. And so we aren't very good about having some of these difficult conversations. But you should start to think about, what's an emergency? What will you do? What will you maybe say you can't do? How are you going to protect your staff? If you can't protect your staff, what are you going to do? Are you going to expect them to come to work anyway? And what do you do if some of your staff members are sick? Are they still supposed to come to work? And how are you going to protect other people from them? And what are you going to do if you don't have what you need? I know this is something that is commonly faced in low resource settings. And unfortunately, this virus is not discriminating in terms of only affecting healthy and wealthy countries and people, but it is good for you to have conversations now while you can to think about how are you going to answer some of these ethical concerns and questions. There was a recent consensus guidelines published in the anesthesia and analgesia from a group of collaborators from the Society for Pediatric Anesthesia, really discussing airway management for surgical patients in pediatrics. And this represented a lot of conversation and commentary by people from around the world. And they had made specific recommendations, not all of which would be easy to apply in every setting. But for example, this is where there's a detailed discussion about the use of video laryngoscopy. And should you always use endotracheal tubes for general anesthesia? I don't necessarily agree with everything that they decided, but this is a good resource to just see what people have discussed and why the management of patients with COVID-19 is more complex than, quote, routine care. So I'm going to switch gears and just talk a little bit about anesthesia outside of the operating room. So we call it NORA in the US, and really stands for non-operating room anesthesia. And there are many places in an institution that require procedures to be done and anesthesia for them. This is just a list of things that happens in my own institution where we deliver anesthesia care outside of our traditional operating room setting. I also recognize that in many larger Ethiopian institutions, you may have a whole separate building where surgical procedures take place for things like orthopedics or cardiac surgery. And there'd be some of the same questions and issues there. But things like radiation treatments, labor and delivery, your different intensive care units, all of these places may also have the ability to give anesthesia, and you should think about how you're going to treat COVID patients in those areas, or perhaps advocate for not having COVID patients go to those areas. Just for a frame of reference, in my institution, we have more than 9,000 cases a year outside of the operating room, which is easily 30 to 40% of our volume. I think our number of anesthetics last year was about 36,000. So that's a lot of patients that we take care of. Our main hospital has 21 operating rooms, but we have 4 surgical centers, each with a couple different operating rooms in different locations. And in our main hospital, we have a lot of other locations where we provide anesthesia. During the initial phases of this COVID pandemic, we did not provide anesthesia in all these locations, but many of them did continue, specifically our oncology area, radiation area, and other radiology locations. So why do people do anesthesia and procedures outside of the operating room? Well, for number one, it doesn't take valuable space in an operating room, which in many hospitals is limited, but it also allows procedures to be done where expertise and equipment is. So for example, a GI suite or an orthopedic unit, all the GI or orthopedic equipment is there, which allows you to then concentrate that equipment. It allows you to develop protocols, have staff that are experts, concentrate your other resources. Most of us in high-income countries, though, struggle with this. We have different names that people assign to it, which may not mean anything to you, but things like remote, Siberia, no man's land, those are all have a connotation of you're out there by yourself. It's as if we're asking you to go to the moon. You don't really have what you're used to. You're not really in your normal, comfortable environment. And part of the reason for that is because you're away from other anesthesia providers or from other people who are used to having around you, like support staff or your specialized airway equipment. And so because of this, many of these more outside of the OR locations have to have duplicated equipment or resources, if at all. And you also may find yourself in places where people aren't as used to how you normally practice. So if you're an anesthesia provider, or even if you are not, but you are now working in an unfamiliar environment in the COVID-19 area, I want you to really start to think about how is this going to change your practice. What equipment do you have? What equipment do you need? If you're using special machines, especially anesthesia machines, but others like ventilators or nebulizer machines, how are you going to protect the machine and how are you going to protect patients from a contaminated machine? Things like monitors, availability of drugs, you should really think about that before you embark on care of patients in these areas. You have to really think about who are the right patients to be there. How are you going to pick them? How are you going to care for them pre-op and post-op in different locations? And you really need to think through, is there anything different you need to do for the care of the patients during this time? And a special word about COVID and non-operating room anesthesia. This is extremely challenging from a logistical point of view. I have spent most of my time in the last 2 months working through these logistical issues. For example, how we schedule patients. In my hospital, we have the luxury of having and requiring testing for all of our patients who are presenting for surgery or procedures. But even then, we have rules about when the testing happens, how it happens, how far in advance it happens, what happens when the test is positive, what happens when the test is not done in time. And many of these procedures don't necessarily involve a surgeon. In our setting, the surgeon really knows the patient and is in the best position to understand how to manage it. But in many of these places like radiology or other procedures, a surgeon isn't involved. So planning that out is complicated. In the case of radiology, a person ordering a test is not the person performing it, is not the person reading the study, is not the one caring for the patient. So in my own setting, I may be anesthetizing or sedating a patient to get an MRI scan, but I didn't order the MRI scan, I'm not reading the report, and I'm not making a medical decision based on the results of it. And so that's a complicated situation. Also, oncology patients, certainly pediatric oncology patients, not only need frequent scans, but they need other treatments such as chemotherapy or infusion of other medications. And so those patients will be seeking medical care frequently, and you really need to figure out how you want to triage and schedule them. And communication, if it was important before, is way more important now. Again, for COVID challenges, not only in the OR, but everywhere else, where are you going to start or deliver the anesthetic? Do you have ability to use a negative pressure room? If so, where is it? In my institution, we have one room available in our radiology unit, but it's not a place we typically have started an anesthetic and then transported a patient throughout the hospital. We're trying to really limit where we do these aerosol generating procedures, mostly intubation, extubation, but also suctioning, so to try to limit contamination of our space and providers. But this is a pretty complicated coordination between multiple spaces and teams. We transport through the hospital. We start and end our anesthetic there, and we recover the patient there, which is different from our normal practice. We've discussed earlier, but we continue to think about, is it okay to use an LMA? What if the patient coughs? What if they have secretions? And what about a non-secured airway? And if you are providing sedation or anesthesia in an MRI area, you have the additional concern about MRI safety, which in my institution is a big concern on a regular day. I put this table together really to highlight the challenges of providing anesthesia care for pediatric patients for an MRI setting, but it's definitely applicable to other areas. So for example, communication between everyone involved. So a physician who's ordering a test like an MRI, the radiology department, anesthesia, intensivist, the ward nurses, the surgical care, the hospitalists, anyone else involved in caring for the patient. The American College of Radiology and the American Society of Anesthesiologists has really discussed that it would be ideal to delay care, if it's at all possible, until this pandemic is reducing in numbers and or until you have ability to do testing on your patient. And are there other things that could be done? For example, a CAT scan or an ultrasound that may give you some information without the complexities of an MRI scan. In proceeding with care, you really have to figure out who the team is, make sure they have what they need, as we discussed. Talk about where you're going to do these aerosol generating procedures, how to limit the risks to to the other people in the room and in the environment. And for MRI specifically, there are certain medical precautions that you have to take into consideration what you can or can't take into the room. If you're going to wear your protective gear, make sure you do that. Take all your metal containing stuff ahead of time and figure out what can go with the patient and what can't. We already discussed the use of PPE, but if you are in the situation that you ever had those air purifying respirators, those are not MRI safe, so you really couldn't take them in an MRI scan even if you wanted to. You have to think about if you're going to transport your patient, how you're going to do that, what way you're going to go, how you're going to clear the hallways. You again want to move all extraneous stuff from the area, especially a scan room or an MRI room. And ideally, after the care of these patients, you discuss what went well and what would you like to do differently. This is a room that we use as an induction room to put patients to sleep and wake them up. And you can see we added this simple yellow chain. And if we have a patient in there, we put a sign on the door so that everyone knows you can't just wander in and out of this room. It's going to be used for the care of COVID-19 patients who are suspected. And so we are really limiting the people in and out. This is what the room normally looks like with all the stuff in it. And you see we have an ultrasound machine and our video laryngoscope and our cart with all our stuff. And then this is a similar room that we took most of the extra stuff out. We have what we need, but we don't have anything extra. There's a lot of other references out there specifically for anesthesia and surgery, but there's clearly other references as well. You can find online discussion groups. You can find webinars like this. You can be in WhatsApp chat groups. And then I've listed a few organizations that have a lot of good resources, and I'll describe and show you what they have. The Anesthesia Patient Safety Foundation really has a lot of detailed information about COVID. They have some joint statements with the American Society of Anesthesiologists. They have a frequently asked questions section specifically about things like anesthesia machine use, how to protect the machine, decontaminate it. They have statements about preoperative testing, decontamination, and optimizing infection control and OR. And these are really well-written statements, and I encourage you to look at their website. They have a whole COVID-19 Resource Center, which is where those frequently asked questions and guidelines came from, and it's a really wonderful resource. For example, I took this off of their site a few days ago, which really talks about screening, and they, again, emphasize that many patients who test positive for SARS-CoV-2 are asymptomatic, and at a minimum, screening should include an assessment of were you exposed to someone diagnosed with COVID-19 in the past 14 days, or do you have any unexplained symptoms, again, fever, cough, and some of these other ones that are considered to be pretty common for COVID-19. Again, this is something you can ask every patient that you come in contact with, whether it's pediatric or adult, and whether they're having surgery or not. If they've been diagnosed or exposed to someone with COVID-19, you should definitely take precautions. The American Society of Anesthesiologists similarly has a lot of quick links. They've been conducting a town hall every week about a certain topic related to COVID-19. I think this week's topic, I can't remember for sure what it is, but in the past, there's been things like care of obstetric patients, testing, and how to reopen or restart your surgical programs. The World Federation of Societies of Anesthesiologists has a lot of good references. Guidance for anesthesia and perioperative care providers. As you can see, they have a special link here for COVID-19. These are things I got off their website yesterday, links to other statements and resources from around the world and different societies. They have specific section guidance for low resource settings, things like decontaminating N95 masks, emergency services, critical care. All these things would be valuable resources for you. LifeBox, many people are familiar with LifeBox in terms of its use and distribution of pulse oximeters. They also have a COVID-19 section. And they have some valuable resources here. For example, the use of pulse oximetry as a decision tool for evaluating and treating patients. Again, not specific necessarily to pediatrics, but certainly valuable in places where pulse oximetry may be one of the only monitoring tools that you have. They have some specific surgical related things, a surgical patient checklist. I didn't copy the whole thing, but this is the top of it. It's again available on their website. Recommendations for preparedness in sub-Saharan Africa, which again, I encourage you to read. It's, you know, specifically mostly for surgery, OB, and anesthesia, but there's clearly a lot of valuable information there. They have some virtual grand rounds, including one tomorrow, that is moderated, I think, and hosted by Dr. Milliard Debreu. And I believe it's in Amharic tomorrow about preparation in sub-Saharan Africa. They have some other videos, which I think are very valuable. And here's some just a collection of websites from of all sources about COVID-19 information, different societies, specifically of anesthesia, and other societies that have specific information for low and middle income countries, World Health Organization, CASEXA, etc. Just to close with a few photos, this is one of our nurses in our radiation center, again, put in her PAPR machine. This is the setup we used yesterday to care for a pediatric patient requiring radiation. So you can see it's a room that doesn't have a lot of extra stuff. We took all the extraneous things out, had just our basic medications and airway equipment, our monitor, an IV pump, an infusion that we were using. And the setup is very different from a traditional operating room setting, but it had everything we need. It had our suction, it had our ventilating bag, our monitor. We were using an IV anesthetic, so we didn't have to use our anesthesia machine. We had our equipment and our hand sanitizer available. This is us in there getting ready or finishing the care of our patient, me, another anesthesiologist that was working with me, and our nurse. And I like to just say, I have a great respect for all of you and the challenges that you're facing, and I wish you well. And primarily, I want to make sure that you take care of yourself so that you can be there for your families and your patients. Thank you very much. Now I'll see if I can see if there's any questions here. Hello, Dr. Radiat. You'll have to unmute your microphone. Oh, there you go.
Hello, Dr. Elizabeth. So I have a couple of questions for you.
Okay.
You mentioned some important, relevant information. I'm very grateful for this topic that you have covered. It's very, very important. I'm very happy that you spoke about it. And so in your presentation, you mentioned the importance of reports, how COVID reports should be detailed and revealed to the public as well as to the healthcare workers. How detailed are they in your setup? Because what we get in our setup is very limited information, and how important it is to get detailed information and what are the contents in your setup.
Well, it's interesting you asked that because I do get a lot of different reports. So I get some from my hospital. I can easily go online and read detailed reports about my city or the county in which I read. But it is a balance between sort of patient privacy and desire for information. So I have access to a report every day in my hospital that tells how many tests they ran and how many were positive. And they tell a difference between employees and patients, but they don't tell me who the employees were or where those employees worked. And so there's some people that makes them very anxious or nervous. So they would say, well, how do I know that the nurse I worked with yesterday wasn't positive? We have a pretty well-organized system that's mostly in the US called contact tracing, which you could see in that report from Ethiopia when they talk about patients. Did they travel? Were they exposed to someone? Or did they have no known travel exposure? In our setup, if I took care of a patient today that turns out to be positive tomorrow, my institution would contact me and discuss that with me and advise me to stay at home, to seek testing if appropriate, or to try to limit my exposure to other people. So it is difficult. I don't necessarily know what else is available to you, but that report I showed you this morning from the WHO and from Ethiopia, I can get on Twitter. So if I can read it, there's definitely, you could read it if you can, get online. And I think that there are probably people who are advocating for better reporting. I just don't know for sure what's available to you. The county I live in, which is basically like a region, I'm not sure exactly what the correlation is in Ethiopia. The person who's in charge of that happens to be an anesthesiologist, and she's a friend of mine, but she does very detailed reports every day, and talks about numbers of patients tested, the areas that they live in, how many were positive. That's not true everywhere, though.
Thank you, Dr. Drum. Dr. Masvin, do you have any questions? I have other couple of questions, but let me give the floor to Dr. Masvin if you have any comments or questions. Okay, if not, let me just proceed with a couple of other questions then.
Okay.
We usually use inappropriately sized nasal prongs to administer oxygen in children. You're probably aware of that, simply because they're not easily available. The appropriate sized ones are not easily available. Can that be aerosolizing, and can that put healthcare providers at a higher risk, even if they're not doing aerosol generating procedures, just simply by administering oxygen?
That is a good question. I don't think that anyone knows for sure. So most of the recommendations are that if you need to use nasal cannula or nasal prong oxygen, to try to limit the amount of flow. So there's flow rates that are called high flow, which are usually more than 2 or 4 liters per minute. So if you can use less than that, that's considered probably okay. There are also times where you may, if the patient would tolerate it, use a simple surgical mask on the patient, but the nasal prongs under it, so that limits the aerosolization to around the patient.
Okay. Okay then. So what's the general recommendation for out of OR procedures for like airway management? Is there a specific recommendation? Which one is superior in the COVID era, LMA or ET tube? Would you recommend just one over the other, or is it just a clinical recommendation that was existing prior to COVID?
Well, that's also a very good question. In that consensus guideline that I mentioned about halfway through that was published, they actually made a strong recommendation to always use an endotracheal tube. However, we've had some serious discussions about that even in my own department. So for example, that patient that I showed you a few pictures that got radiation treatment last night, that patient is getting 11 treatments. And the first time she was treated, before she turned positive, we used an LMA. So we had some serious conversations, both in our department, but also with our institution and infection control and oncology and radiation oncology about the need to intubate. And so what we decided for her is that we thought that we could safely anesthetize her using an LMA, but we carefully thought through how we were going to do that, the place in which we were going to have her be anesthetized and recover, and recognize what risks that posed. We ultimately decided that the risk of intubating her every day was probably greater than the risk for us to do a well thought out, well planned anesthetic using propofol and an LMA and keeping her deeply asleep. So we've chosen to do that. Our MRIs, we've done about 4 patients that we knew were COVID positive. So for them, we actually did intubate all of them because there were other conditions. One was a 5-month-old, which we weren't comfortable putting in the MRI scanner without controlling her airway. Another one was having a 3-hour procedure. Another one was combined with a surgical procedure. And the 4th one had a distended abdomen and some vomiting, and we weren't comfortable sedating her without that, which is pretty complicated to figure out how to conduct that. So I think the answer is it does depend on the patient and it does depend on your setup, but recognize that anything that you do, whether it's an LMA or nasal prongs or an endotracheal tube, does have the potential to generate aerosols. And ideally, you want to protect yourself and the environment.
Thank you, Dr. Liz. Just one final question from me. Even if we're not doing aerosol generating procedures, the fact that we don't have those, the HEPA filters, we don't have the negative pressure rooms, or we don't have appropriate scavenging mechanism, even if it's not in the OR, or it could be in the ICU, for example, should we be strict on the PPE, or would you recommend other just full PPE at all times in such procedures, even if we're not doing aerosol generating procedures?
Well, I think it does depend on what you have available to you. So in our institution, our guidelines are what we call modified expanded PPE, which is a face mask, eye protection, gown, and gloves in patients for whom you are not doing aerosol generating procedures. And then if you are, you would add the extra layer of the N95 mask. I think things like appropriate use of mask and eye protection is probably one of the best things you can do. One of our infectious disease doctors talked about cases both in our hospital, but I think also in China, looking at the number of providers who got exposed to SARS-CoV-2 and which ones actually got sick with the virus. And one of the common themes that they found was people who did not wear eye protection were in situations like intubating or during aerosol generating, were at higher risk than those that did. And again, because the mouth and the nose and the eyes are places where the virus can enter your body. And if you don't cover them or protect them, and or if you don't stop yourself from touching your face, that's how you're going to get the virus. So I would say for any setting like an ICU or somewhere else, if you can wear a mask and eye protection, that's probably the best thing you can do. If you have access to the N95 masks and ability to wear a gown, I think that gives you an extra layer of protection. But if all you have is a regular mask, and even if it's glasses that don't have any, change of magnification in them, that does protect your eyes. And then really try to be vigilant and rigorous about washing your hands after you are around a patient before you touch your eyes and your face. Those are probably the simplest things you can do.
Thank you so much, Dr. Elizabeth Drum. I think Dr. Masfin is unable to reconnect with us to conclude, but it has been such a great discussion. It was an honor to have you here with us to speak to us about pediatric care of COVID positive patients, as well as out of OR care in the era of COVID-19. Thank you for telling us your experience. It's extremely helpful. So I hope in another episode, you can also share your experience to other audiences as well. Thank you so much for joining us today and teaching us a lot.
Thank you so much for inviting me, and I wish you all good health and be safe and healthy. So thank you very much.
Thank you. Thank you. Be safe, you too.
Thank you.
Bye.
Okay, bye.
Bye. Bye.